Hello and good morning. Thank you for the opportunity to present our work on Entrust, a virtual patient assessment platform for Entrustable Professional Activities, or EPAs, graduate medical education. In this talk, we plan to define what are EPAs and discuss particularly what the American Board of Surgery has planned for them, demo our Entrust virtual patient simulation platform, which includes both an assessment component and an authoring portal, present the validity evidence that has been collected so far on Entrust, share about a pilot we performed in partnership with the College of Surgeons of East, Central, and South Africa, also known as Cosexa, for one of their high-stakes examinations, and finally talk about ongoing and future directions for it. In 2018, the American Board of Surgery initiated a nationwide pilot across 28 general surgery programs, +1, to explore the use of entrustable professional activities in competency-based surgical education, with the intent of implementing EPAs for the entering PGY1 general surgery residents in 2023. An EPA is a unit of professional practice defined as tasks to be entrusted to an unsupervised trainee once he or she has attained a specific level of competence. They are specialty-specific, independently executable, observable, and measurable. They have been adopted by UME and GME with the goal of moving towards a competency-based residency education paradigm. An EPA can be thought of a discrete domain of clinical activity in which trainees are granted increasing levels of autonomy as they progress in competency in that domain. The initial 5 core general surgery EPAs designated by the American Board of Surgery include evaluation and management of a patient with inguinal hernia, gallbladder disease, right lower quadrant pain, trauma, and providing general surgical consultation to other healthcare providers. Beginning in July 2023, general surgery residency programs will be required to evaluate residents in 19 core general surgery EPAs, which have been recently described by the American Board of Surgery. The American Board of Surgery has outlined 5 defined levels of entrustment for each EPA, progressing from limited participation to who can teach others. And this includes all phases of patient care: preoperative, intraoperative, and postoperative care. As EPAs are intended to inform the degree of autonomy granted to a trainee, there is a great need to develop objective and rigorous, yet efficient and scalable tools to assess clinical competence. Many programs have focused on operative autonomy. While this is important, each EPA domain encompasses more than just technical skill and requires a trainee to make informed, safe, and at times complex and highly nuanced decisions across a spectrum of clinical presentations, not only intraoperatively, but also pre- and post-operatively. To address this need, we formed a collaboration with Dr. Edward Melser, Director of Alternative Learning Technologies Lab at UCSC Santa Cruz, to create Entrust, an innovative platform to author and deploy virtual patient simulation case scenarios to assess surgical decision-making competence and readiness for entrustment. Here I will first show a demo of the assessment platform, which is the interface that the examinees interact with.
Entrust platform is divided into 2 basic modes, the simulation mode and the question mode. The patient scenarios begin in the preoperative clinical setting, either in the emergency room for urgent or emergent cases, or the outpatient clinic setting for elective cases. Here you will initiate the workup of the patient. The patient's chart is located on the right side of the screen. The front page provides a brief clinical vignette. A visual of the patient is on the left side of the screen. The patient's vital signs appear on the monitor in the central upper area and reflect the clinical status of the patient. The vital signs may deteriorate over time, but can change based on interventions performed, such as fluids, medications, and procedures. For clinic patients, the vital signs appear in the patient's chart on the right side of the screen. To examine the patient, you can hover over and click on regions of the body to elicit physical exam findings. As you do so, the exam findings will appear both as a pop-up and under the physical exam section of the patient's chart. While performing the physical exam, you may be prompted to answer a pop-up clinical question. Click on an answer choice in order to proceed. The action buttons to work up and treat the patient are located on the computer monitor in the middle of the screen. You can order labs or imaging studies. The labs and imaging menus are organized into subcategories to help you find the test you are looking for. In addition, you may type into the search bar to look for a particular order. Click on the diagnostic tests you would like to order, then click the Submit button. The orders will not become active until you press the Submit button. Once you enter the test or intervention, the status of the order can be tracked on this In Progress screen. After ordering diagnostic tests, click on the corresponding tabs on the right side of the patient chart to review the results. Under Imaging, you may be provided with a representative key image, which you must interpret in order to arrive at the diagnosis. Under Interventions, you can order IV fluids, medications, and blood transfusions. Click on Procedures to perform bedside procedures, such as insert a peripheral IV, an NG tube, or Foley catheter. These menus are also organized into subcategories to help you find a specific intervention. Finally, if you would like to order a consult from a medical specialty or surgical subspecialty, click Consult to access the menu of consult options. If you perform an FNA or a biopsy, remember to also place an order for cytology or pathology under Labs in order to view the pathology results. For outpatient elective cases, after evaluating the patient, you can order the relevant workup. As you do this, the patient will still appear in your clinic, even though in reality, these tests are likely to be performed after the patient has left the clinic. You will be awarded points for selecting appropriate key tests or essential interventions. Some selections are neutral, which will not result in gain or loss of points. Points will be deducted for ordering unnecessary tests or harmful interventions. Once you have completed the workup of the patient, you can conclude the simulation portion of the scenario by selecting one of the disposition icons at the bottom of the computer monitor. Disposition options for emergency department patients include discharge home, admit to ward, admit to ICU, and go to the operating room. Disposition options for clinic patients include non-operative management and consent for OR. Once you select the disposition button, you will proceed to the question phase of the scenario, where you must answer a series of single best answer multiple choice questions. You will be awarded points for answering correctly and lose points for answering incorrectly. These questions may include anatomy, intraoperative decision-making, and management of post-operative complications. Once the scenario has concluded, you can proceed to the next case.
The Entrust platform also features a user-friendly authoring platform that allows content experts with no background in software engineering to create and deploy cases on virtually any clinical domain or disease process. It is highly customizable, and once a case is created, it can be edited and it is spontaneously reflected in the case scenario. Here I'll talk you through a demo of the authoring portal. In the authoring portal, you have the ability to customize the menu of orders. In the authoring portal, you have the ability to customize the menu of orders that will pick the choose from. There's a standard default set of labs, imaging, and medications and interventions. You are able to add specialized orders if you wish. throughout the components of the case and will create the clinical vignette by populating these fields. Next, we are brought to a patient therapy junction where you can customize the character age option ranges select infants. There is even an option to select a called backboard for trauma specialists. Next, you write in the vital signs of the exam, physical exam. You can even upload photographs and get vitals of the exam as well. Then you review and customize the menu of orders for the case. The orders have a default score assigned to them. For radiology orders, you can type in a free text result or upload an image. For each order, you assign a score based on whether it is independent, appropriate, or harmful for the patient. Here you can also assign values to disposition choices. You can also once the Entrust assessment and authoring platform were completed, we authored cases based on the American Board of Surgery Inguinal Hernia EPA. As you can see, the Inguinal Hernia EPA encompasses comprehensive workup and care of the patient with an inguinal hernia, from diagnosis to management of post-operative complications. Cases were designed using the essential functions and expected behaviors outlined by the American Board of Surgery pilot for resident performance in preoperative, intraoperative, and postoperative settings. In addition, the ABS provided detailed example vignettes for each resident at each EPA level of entrustment. We authored and iteratively developed 4 inguinal hernia case scenarios based on these EPA descriptions outlined by the American Board of Surgery. All actions are scored on the back end according to an expert consensus-derived scoring algorithm. Points are earned for ordering relevant labs and key interventions and answering multiple choice questions correctly. Similarly, points are lost for performing inappropriate, unnecessary, or harmful actions and answering multiple choice questions incorrectly. I'm going to turn it over to Liebert to go over our validity evidence.
So we piloted a 4-case Entrust Inguinal Hernia module at Stanford in May of 2021 with 43 of our surgical residents from varying PGY levels. They first completed a demographic survey followed by a tutorial and then a practice case and 4 inguinal hernia cases. And this was performed in a proctored setting, and participants completed a post-completion Qualtrics survey. So what we found was that there was a statistically significant increase in Entrust grand total score that was observed with increasing PGY level. And similar findings were observed for the preoperative simulation mode, the intraoperative question mode, and the postoperative question mode across the 4 cases. And there was no correlation seen between score and prior video game experience. We also looked at a case level, and the preoperative subscore increased with PGY level for all cases. However, as you can see in the 3rd panel, in some cases, such as the case of strangulated inguinal hernia, there was significant variability that was seen in performance even within PGY level. Similarly, for the intraoperative question mode subscore by case, this increased with PGY level for 3 of the 4 cases. So for cases here, the elective inguinal hernia, a strangulated inguinal hernia, and elective bilateral hernia. For the acutely incarcerated inguinal hernia, there was no significant difference between PGY level and performance in that case. We also evaluated the relationship between Entrust performance and operative experience and found that there was a strong correlation between Entrust grand total score here on the y-axis and the intraoperative score for both grand total score and intraoperative score, and correlated with self-reported inguinal hernia operative case volume. And you can see that this was particularly strong for those residents with fewer than 20 inguinal hernia cases. Following completion of the Entrust Inguinal Hernia module, the residents completed an online Qualtrics survey, and this contained embedded questions from the system usability scale. This scale, abbreviated SUS, is a 10-question scale that possesses validity evidence to evaluate the usability of technology platforms. And what we found was that the mean and median SUS scores for Entrust were 77 and 80. And this can be interpreted as a good usability score, which is similar to the usability score of Microsoft Teams and the iPhone, which have been published in the literature. So now I'll shift gears to talk about our recent collaboration between Entrust and Cosexa. So as Dr. Lin had mentioned, Cosexa stands for the College of Surgeons of East Central and Southern Africa. And this is, we formed a collaboration in May, shortly after the May 2021 Entrust pilot. Cosexa is the largest surgical training institution and accrediting organization in sub-Saharan Africa. It represents 126 hospitals, more than 800 trainees, and more than 1,400 members across 14 countries. So we developed a collaboration with Dr. Abebe Bekele. He's the chair of the Examinations and Credentials Committee in Cosexa. And he was interested in transitioning the membership of the College of Surgeons exam, called the MCS exam, from a traditional in-person oral examination, which was based on OSCE stations, to a virtual examination. So this MCS exam is taken by surgical trainees between their after their PGY2 year of training, and can traditionally contain 12 to 15 oral examination scenarios. For the November 2021 MCS exam, we worked with Dr. Bekele and we developed 3 cases on Entrust, so 1 in hernia, 1 in thyroid, and 1 in breast. And these were covered similar case content to the 3 traditional OSCE cases in these areas. And then these cases were uploaded to the Entrust authoring platform. So the study design was that the participants, we had 110 participants who completed their OSCE examination of 12 stations via Zoom. It was a 3-hour exam with oral examination. And then following that, the participants completed the online Entrust exam containing 3 cases, which took approximately 45 minutes and was completed online via secure password-protected user ID and login. So this is a screenshot of the login page where examinees would enter their candidate ID that had been given to them and a provided passcode. These are screenshots of the 3 cases. So the first case was a strangulated inguinal hernia case for a massive scrotal hernia that was managed operatively and had multiple questions. The second case was a thyroid case of thyroid toxicosis, where it initially required the patient to be admitted to either the ward or the ICU for further management, where questions were queried in that mode, and then prior to being taken to the operating room. And then the final case was a breast cancer case for a clinic patient that was managed operatively and then required the management of postoperative complications. So these are representative screenshots, but each case would include approximately 5 to 10 additional clinical decision-making questions after the simulation portion. So to look at the results, what we saw was that when graphing the Entrust total score compared by MCS outcome, that score was significantly higher on Entrust for those who passed their MCS exam compared to those who failed. We also looked at the correlation of Entrust score with the traditional oral exam OSCE cases, and this is an objective structured clinical examination. So we found, for example, at the case level for the thyroid case, that there was strong correlation in performance. If we looked at the combined Entrust for the 3 cases in Entrust compared to their combined total for their 3 cases in the OSCE format, we also saw a strong correlation. And when we looked, finally, there was a statistically significant correlation of examinees' Entrust total score compared to their overall MCS exam percentage. And following completion of the MCS exam, examinees completed a Qualtrics user survey. When asked about their preferred exam format, approximately 70% preferred that the Entrust exam be either all or a portion of the MCS exam for future years. We also asked examinees their interest in using Entrust as a learning platform rather than just an assessment platform, and the vast majority expressed interest in also using Entrust for formative self-assessment and learning. So based on these results, in discussion with Cosexa in recent meetings, Dr. Bekele plans to utilize Entrust as an assessment platform for future MCS case scenarios. So with the November 2022 examination, it's planned as a 15-case virtual examination, which will contain a combination of the traditional oral OSCE exam cases and Entrust platform cases. Finally, in conclusion, the American Board of Surgery is introducing the evaluation of 19 core general surgery EPAs that will be required for general surgery residency programs beginning in 2023. And based on the evidence that we've collected so far, Entrust has initial validity evidence for the ability to assess surgical decision-making in trainees. It demonstrates good usability similar to other hardware and software platforms. And based on this, we feel that Entrust has potential as a tool for the assessment of EPAs in general surgery residency programs. And so what we envision is that Entrust might be able to be utilized as a complement to other app-based platforms for real-time microassessments of EPAs. So for example, as a complement to Simple or other similar platforms, and that particularly for nuanced or uncommon, but critically important decision-making scenarios that are infrequently directly observed, Entrust would provide that ability to obtain objective information about resident clinical decision-making. And finally, Entrust holds potential not just for the assessment of EPAs, but also for the assessment of high-stakes assessment globally. Our areas of ongoing development are in preparation for the November MCS exam, preparing for increased high-stakes exam security. We've expanded the authoring platform to allow additional accounts so that other institutions could create and deploy their own cases. A focus on increased usability, including expanded tutorials. And in addition to expanding content and additional functionality, such as ability to, in real time, adjust ventilator and drip settings, we also plan to expand to mobile compatibility, specifically with the iPad, as we anticipate that this will help to make this more accessible as a learning platform globally. So our future directions are in 2 areas. One is locally and nationally, and that is really focusing on alignment with the American Board of Surgery EPAs and with standard setting. And in preparation for this, we'll be implementing Entrust at Stanford and ahead of the July 2023 EPA rollout. We plan to develop the Entrust module not just for inguinal hernia, but for all of the 19 American Board of Surgery core EPAs. And our hope is that eventually Entrust could be a tool that could be used nationally by other general surgery residency programs to assist them in evaluating EPA levels annually for their residents. And then additionally, we are working globally with Cosexa in attempts to secure funding to help implement Entrust as an assessed platform for their ongoing Cosexa MCS exams, and eventually to develop Entrust as a learning platform that's mobily compatible for global use in low and middle income countries. So this is our team, including Melissa, who recently joined our team. She's a first-year medical student who will be working with us this summer on a Med Scholars project to look at the usability of Entrust in different learner populations. And to our UCSE collaborator, Dr. Melser, who's been instrumental in helping us to identify team members. So the team members that are listed here are all either students or recent graduates of UC Santa Cruz. All of the artwork in the program that was done on Entrust was performed by, again, either students or students who are recent graduates who stayed on with our team. And in particular, Jason Tsai, our primary programmer, and Fatima Camacho, our artist. And then an acknowledgement, and finally, thank you to all of the faculty and staff in the department and division and residency program who've helped to make this work possible, including the leadership in supporting Entrust with seed grant funding, to Dr. Sherry Wren for her support of Entrust collaboration with Cosexa, and to Espire for statistical support.